Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. This is your opportunity to get your COVID questions answered. Today is Thursday, December 17th, and I want to start by wishing everybody happy COVID-19 vaccination week here in Chicago. We kicked off with our first vaccines in Chicago on Tuesday. We received the very first doses of COVID-19 in Chicago less than 24 hours before that on Monday, and we've been receiving vaccine really throughout this week. We expect to get 23,400 doses of COVID vaccine right here in Chicago in this first week. We've got additional doses that are coming from the manufacturer, arriving at some more of our hospitals today, and everything is on track for us to get that vaccine that we expected. All of this first vaccine is going to our hospital workers. And as you've heard us talk about, we've worked hard here in Chicago to make sure that all of our hospitals are able to access COVID-19 vaccine really at the same time. And so while some of our larger hospitals have been directly receiving vaccine shipments, if they have the ultra cold storage, for example, and can handle much larger numbers of vaccine in this first week, even our smallest hospitals have been receiving vaccine, and with the support of the health department, where we have the capability to keep vaccine at that ultra cold storage level. And it's really exciting. Our first doses of vaccine were given at the Loretto Hospital in Austin. That hospital, of course, is one of the hospitals that has served a community that's been hardest hit by COVID in terms of deaths. We have still disproportionately seen COVID deaths in Black Chicagoans. But it was not just the Loretto Hospital. We also had the president from Norwegian American Hospital, as well as both vaccinators and staff from Norwegian at the event. And Norwegian American Hospital in Humboldt Park is one of the hospitals that serves a lot of Latinx Chicagoans, some of our areas that have been hardest hit in terms of cases. If we count all the way back since the beginning of the outbreak, about 46% of the cases of COVID-19 in Chicago have been in Latinx Chicagoans. But this ceremonial event was 5 people vaccinating and 5 people getting vaccinated. And the people getting vaccinated came from 3 different hospitals: the Loretto Hospital, Norwegian American Hospital, and University of Illinois at Chicago. And similarly, the vaccinators came from different hospitals. And we wanted to highlight really those 2 hospitals in particular, and really all 3 of them, because number one, they are some of our safety net hospitals, but also given the fact that they've been hardest hit, and the leaders of those 2 hospitals lead the health equity group in the Illinois Hospital Association. We are really committed here in Chicago to make sure that as this vaccine rolls out, it is widely available, it is distributed equitably, and that even places that may be smaller will not be left behind. You're going to hear a lot about equity as we talk about this vaccine moving forward, and I want you to know that I couldn't be happier about the way that COVID vaccine has arrived, what the data behind it looks like, and how we are going to continue growing COVID-19 vaccination here in Chicago. I've been excited to see how many healthcare workers are signing up and volunteering, saying, I want to be first, I want to be early, when is my vaccine coming? There's been a lot of anticipation and excitement around that. And the good news is that today, Thursday, the FDA is meeting to consider the emergency use authorization for the second COVID vaccine. So the one that was approved, given the emergency use authorization just 1 week ago today, was the Pfizer vaccine. The second one, the Moderna vaccine, is being considered today. If the FDA grants the emergency use authorization, which we expect, given that the data looks very good for that vaccine, again, more than 94% efficacy, excellent safety profile. If they again grant emergency use authorization, we would need the ACIP, the Advisory Committee on Immunization Practices, and the CDC to meet, which would likely happen over this weekend. And then if they also give the go-ahead, we could be adding a second COVID vaccine to our arsenal here in Chicago with the Moderna vaccine. So we have systems in place to be able to handle as much vaccine as is is allocated, that's all set at the federal level, purely based on population. So things have been going well. It's a huge operation in terms of logistics, communication, making sure people have the training. There's a lot of training to make sure that people understand how to keep the vaccine at the temperature that's needed, how to make sure the pharmacists are drawing it up appropriately. One of the reasons we chose to vaccinate 5 people at once in our first ceremonial vaccination here in Chicago was that there are 5 doses in a vial. And so we are highly mindful about making sure we are not wasting any vaccine here. And that's part of why we went ahead with that way. So I've been hearing from a lot of people individually who are starting to get vaccinated, starting to share pictures on Facebook, starting to share their stories. And it's just the beginning of what is going to be many months of a vaccine campaign. But I'm feeling very, very pleased that we've been able to get started here in Chicago with what is the beginning of what I'm confident will mark the end of COVID in terms of having these major impacts on our lives. So I know a lot of you probably have a lot of questions about COVID-19 vaccine. We'll be focusing a lot on those, and you can go ahead and put them in the box below, or you with the hashtag AskDrArwady on either Facebook or Twitter. We'll be taking those live. There's another opportunity tonight at 6 p.m. We're doing a large citywide virtual town hall about COVID vaccine. I'll be joined by 3 members from CDPH who are all leading on different parts of COVID vaccine, whether that's logistics or communications, outreach, administration. And there will be another opportunity for questions there. But let's take a quick look at the data first. So as always, chicago.gov/coronavirus, right up at the top, if you take a look, there's a tab now that says vaccine, and we're putting more information under that every day. But in the middle, there's a tab that says latest data, and underneath that is our data dashboard. So if we take a quick look at that, our current positivity rate across all of Chicago is at 12%. And if we just blow up a second what positivity has looked like, I'll remind you, we would like this positivity to be back down under 5% ideally. So we're nowhere near where we want to be. But what you can see is that back in the first wave here, we were up as high as 30% when there was very little testing availability. We were able to bring this down under our target, that's the dashed line here, of 5%, and really keep it there, just occasionally dipping above it throughout the summer. And then unfortunately at the beginning of October, this is when our second surge started, despite a lot of increases in testing, still saw this positivity, which is the percentage of tests divided by all the tests that are done, shoot up very quickly, peaked out right around 16% in mid-November. We saw this falling, and then we did see an increase here really after Thanksgiving, as expected. And now we are seeing that come back down. So I'm glad to see it back to 12%, but we have a long way to go still to get down to 5%. If we take a look, our testing numbers are in the 15,000 range. That's about twice what we were doing at the beginning of October. We also had some dip and rise there. And our daily case rate is about 1,534 per day right now. That's down from a week ago. But again, I'll just show the graph real quickly here. Here's the graph by rate, and you can see, let's just blow it up, that here too we had this huge spike all the way up through November, started to really see that come down very nicely, saw a post-Thanksgiving spike, and then now we are on the way back down again. So very hopeful that over these next few weeks, we're already into Hanukkah, Christmas is coming next week. We've had a lot of celebrations, both religious and non-religious, take place this time of year, and reminding everybody that we have a lot of COVID. We are in a high risk, by any way that you slice it, setting for COVID, and it is the time for alternative gatherings, not your big traditional holiday gatherings. I know that's hard. It's especially hard in December, and it's been a long year already, but please, the vaccine, although we're getting started on it, it is months from being able to have enough people vaccinated that we'll start to see major impacts in terms of spread. And we have to keep doing the things that we know work: the masking, the social distancing, the hand washing, and importantly, not giving COVID the opportunity to spread. That means not inviting people into your home who don't live there, not traveling, really trying to stay home unless it is for essential things. I know how hard that is, but I ask you, it's the best thing for yourself, for your family, and for Chicago. We need to get this curve continuing on this downward trajectory. All right, so I think with that, let's go ahead and turn to some questions. All right, Mary Kay on Facebook. Oh, we have a lot coming in already. My question is, I have allergies. I'm concerned I will not be able to get the vaccine. And Joshua Duke has the same question. He's heard not to get the vaccine yet. So there was a lot of attention to allergies because in just I think the very first day of vaccine administration in the United Kingdom, there were 2 people who had a severe allergic reaction. And then actually just yesterday, there was one person in Alaska who also had a severe allergic reaction after receiving the vaccine. We call it anaphylaxis when somebody has a bad allergic reaction, and that's a big deal when that happens. People who have a history of severe allergic reactions, meaning that they could have difficulty breathing or they're having their lips swell up, often will carry an EpiPen. And for people who have a history of these severe allergies, bad enough that you need to carry an EpiPen or something around, there's been a recommendation to wait to get vaccinated, at least out of the UK, while they're looking into this some more. I would say if you have a severe allergy to the point where you're carrying an EpiPen, please have a conversation with your doctor about whether they recommend getting COVID vaccine right now. For people who have just regular allergies, if you have seasonal allergies, if you're allergic to cats or dogs, etc., that is not a contraindication to vaccine, meaning there's not been a recommendation that you should not get vaccinated. Every person, though, this is the important part, every person, as they are getting vaccinated, there's some counseling and some questions that are asked, including about allergies. Anyone with a history of anaphylaxis, meaning these bad allergic reactions to any part of this vaccine, should not get vaccinated. And there is a time period that we have to monitor everybody who gets the COVID vaccine. So after you get the shot, you have to monitor people for at least 15 minutes, and then if there's a history of allergies, et cetera, for some people there's a requirement to monitor for 30 minutes. And typically where these severe allergic reactions come, they usually are in the first minutes after vaccine. Now, I don't want to scare people too much. This is something that we are absolutely prepared for and expect to happen to a small number of people around vaccine. Every time anybody gives a vaccine, not COVID vaccine, any vaccine, flu vaccine, childhood vaccines, you're actually required to have the medication you would use in case someone had a severe allergic reaction. So as somebody who sometimes carries 1 dose of the flu vaccine, for example, if I'm going to vaccinate the mayor or if I'm going to vaccinate somebody from media, even if I have 1 dose of flu vaccine, right along with me, I have the package of the medicine that I would need in the unexpected event that somebody had an allergic reaction. So it's something we prepare for to be rare. It's not a reason to be afraid of vaccine, but if somebody has had a serious allergic reaction, it's something you should talk to the doctor about, and know that we are very prepared. We will be here in Chicago anytime anybody's getting vaccine, not just for COVID vaccine, in the unlikely event somebody does have an allergic reaction. Okay, we have Lisa Dorna on Facebook. Are there big differences between the Pfizer vaccine and the Moderna vaccine? So there are a few differences between these vaccines, but not very big ones, to be honest, based on what I've read so far. I will be looking, and you might recall that I mentioned we have a scientific vaccine work group here in Chicago of experts around Chicago who are looking at the data related to these vaccines and the FDA process. So the meetings are going on today at the FDA. Right now they're looking at all the data, talking it through. I'll be looking at some of the high-level reviews. We've got experts really looking at all of these pieces, and we'll obviously want to know all of the ins and outs related to both of these vaccines. But at the highest level, they're very similar. They both use the same technology, this messenger RNA technology. And one of the main differences is they've been able to figure out slightly different ways to keep the mRNA stable. The mRNA, messenger RNA, it's basically just a little piece, it's like a recipe, a set of genetic instructions that get injected into a muscle cell and teach your cell how to make a protein. And in this case, it's teaching it how to make a protein that is a part of the little spike of the coronavirus. And then your immune system can recognize the next time you see coronavirus, after you've been vaccinated, and know how to fight it off without ever making you sick. So they both use this same mRNA, but one of the trickiest things, mRNA, by the way, they've been studying mRNA for use in vaccines for like 17 years. It's not brand new, but it's the first time that we've had it come all the way to full use because it is the mRNA itself is very fragile. It's good when you use it as a vaccine. When we inject it into somebody's arm, it doesn't hang around. It really dissolves very quickly. But there was a lot of work to figure out how to encase that mRNA in something that would help keep it stable. And so the two companies figured out different ways to put the mRNA in little like fat globules, basically, that help keep it stable. So the Pfizer vaccine has to be kept in this ultra cold, like minus 80 Celsius temperatures, whereas the Moderna vaccine, they were able to figure out a little bit of a different way to keep it stable. So that one has to be frozen, but not ultra cold. And that's very good news because it means that we'll be able to use that Moderna vaccine. There are still a lot of logistics. You have to keep it frozen, but it's not that ultra cold requirement. So we expect to use the Moderna vaccine here in Chicago in our long-term care facilities more, for example, in a lot of our outpatient facilities that are less likely to have any of this ultra cold. And we will be, from a logistics standpoint, using a lot of the Pfizer vaccine in our hospital settings, in the settings that the health department is vaccinating from, because we can be really sure that we've gotten the logistics of this right. We want to be absolutely certain that the vaccine that we give has been kept to all the right temperature with all the right, training that goes around it. So I'd say the main way it's different has to do with actually how the companies have been able to figure out how to keep the mRNA stable and the different temperatures that are required. The other major difference is that in the trials, the Pfizer vaccine requires 2 doses 21 days apart. The Moderna vaccine requires 2 doses 28 days apart. So again, behind the scenes, a lot of logistics there. It'll be important that people get their second dose of vaccine with the same type, the same manufacturer. And so we are thinking a lot about who is getting vaccine and how are we distributing that to ensure that there are as few opportunities for errors as possible as we're doing that. People will be getting their second vaccine the same place they got their first vaccine. There's reminder systems and other things built in, but that's one other way that it's different. But the efficacy data, at least what I've looked at online, looks the same basically and fantastic. The Pfizer vaccine, 95% efficacy. The Moderna vaccine, 94.1%. Those are the same. There's nothing different between those in terms of margin of error. So I hope that answers some of the questions. I'm sure there will be more. But bottom line, works the same way, similar efficacy, excellent safety profile, of course, in both of them. There's no chance that they would get this emergency use authorization if there were serious safety concerns. And they'll have all of the same follow-up related to side effects and others as we move forward. Hector Lyon from Facebook and actually Sanchez Javier from Facebook are both asking how long will the vaccine stay effective and how long is the immunity for? And Sanchez Javier is also asking if you have asthma, can you take the vaccine? The answer is yes. Asthma is not considered a reason not to get the vaccine, and we'll come back to the immunity question in a second. This vaccine does not have any COVID-19 virus in it. It doesn't have killed COVID-19. It doesn't have inactivated COVID-19. It doesn't even have a piece of COVID-19. The vaccine, the side effects that we've seen in the trials that some people have gotten, the most common one has been a sore arm. Some people have gotten a day or two of some flu-like type symptoms. Some people have felt chills or muscle aches. A few people have reported some fever. That is not COVID-19. It's not shortness of breath. It's not serious side effects like that. It's just your immune system. That is the process of your immune system learning what COVID looks like and learning how to protect you against COVID without ever making you sick. So the good news is that in the trials, there were people with a number of underlying medical conditions, and the vaccine had similar efficacy, similar 95% protection across those underlying conditions, just as it had similar protection across race, ethnicity groups and across age groups. We will continue certainly to be studying this and following up, but there is no reason, certainly at this point, that I would in fact recommend that somebody with a history of asthma definitely get the vaccine, because we know that your risk of, if you get COVID, of getting seriously ill with COVID, hospitalized or even dying, is higher. I'm especially interested in people who have the underlying conditions, feeling confident about getting the COVID-19 vaccine so you're protected from ever getting COVID. So for someone who has asthma, diabetes, et cetera, the risk-benefit ratio is even greater and better for you in terms of getting the vaccine versus sort of risking getting COVID. So that's a good question. Back on the part about how long will the vaccine stay effective? We don't know yet, is the bottom line. Remember that we have only had COVID on this planet, not even a year. And so the trials, even the longest trials of the vaccine have been in the 6-month range, give or take. And the large trials, the FDA waited, which I think was smart, waited. They wanted to see at least 2 months of safety data after vaccine. And where we look back at the history of vaccines, where we have seen problems ever, safety problems related to vaccine, they tend to come up very quickly after vaccination. It would be quite unexpected to see problems emerge many months after vaccine, although certainly we will be following to make sure of that. But the FDA wanted to see at least 2 months of safety data in the tens of thousands of people in the trials. But that means that even in these large trials, folks have been only followed for 2 months. We are hopeful, and the vaccine experts are thinking that this vaccine is likely to have fairly long-lasting immunity. The good thing about depending on a vaccine versus natural immunity is that with a vaccine, there is a measured dose of vaccine that you get, which is known to produce a more predictable immune response. In real life, in the wild, when people are just being exposed to COVID, we see, there are people who get exposed to a little bit of COVID and don't get very sick. There are people who get exposed to a large amount of COVID. They may get more sick. And more importantly, people's immune systems respond very differently, depending on, your innate immune system, your underlying conditions, how much COVID you were exposed to. The idea of the vaccine is there's been a number of trials where they follow up and look for immune markers in people's blood, et cetera, to really know how much dose you get to get a predictable immune response while keeping the side effects, as minimal as possible. And so we just don't know yet. But different than the flu vaccine, for example, you have to get a flu vaccine every year. That's because the flu vaccine mutates like crazy. There are lots of different strains of influenza. You might have heard of, there's flu A, there's flu B. You'll hear H1N1, H1N2. These are strains that are different enough genetically, because flu itself mutates, that we have to create a new vaccine every year, literally by looking to see which strains of influenza were circulating in the last 6 months and taking a best guess about which strain should we pull in to this year's flu vaccine. COVID virus at this point has not done a lot of mutation. There are not separate strains of COVID. There has been a little bit of genetic mutation, but nothing to the point that we think would affect the development of the vaccine. And these vaccines are being developed in very clever ways. For example, these first two, they're just focused on a little part of the spike of the coronavirus itself, meaning that unless you saw a lot of mutation in that spike part, you wouldn't be very concerned about mutation that could occur in other parts of the coronavirus. So we are hopeful, and some of the experts think that it's likely that that protection with the vaccine would last on the order of years, but we don't know yet. We'll only know that as we're able to follow up people long-term after the vaccine. So bottom line is we want people to really get it this year, and as we learn more, we'll be be able to say when people may need a booster shot. That could be as soon as a year from now. I think more likely it would be multiple years from now. In a best case scenario, never, but we just don't know yet. And again, the immediate protection that it is showing is what is going to get us out of COVID in terms of affecting society in major ways. I don't think we are going to eradicate COVID. It's going to be with us. It's just that we'll be able to use routine vaccination to help keep it down, just like we do for measles. Measles is not eradicated from the world, but we don't worry about large outbreaks from it because we have very high vaccination rates with a very safe and effective vaccine. Okay. People are asking a lot, have I gotten the vaccine or will I be vaccinated? Beverly Mills and other. I absolutely will get the vaccine. I have not gotten it yet because I am abiding by the guidance here in Chicago and our own prioritization, where we are first, even within healthcare workers, prioritizing our hospital-based healthcare workers, the ones who are working every day taking care of COVID patients in ICUs and emergency departments and COVID wards. That's who's getting the vaccine first in the hospitals. I anticipate getting vaccinated just as soon as we move into our outpatient phase of healthcare workers. So we expect that that's going to happen. It's basically going to start in January. We may start in a preliminary way in that very last week of December. It all depends. Does the Moderna vaccine get approved? How does it come in? What do our numbers look like, et cetera? But as we start to move into vaccinating outpatient healthcare workers, also as the city of Chicago starts to stand up our larger mass vaccination sites, which are, again, only going to be open to healthcare workers by appointment, but they'll be focused on healthcare workers who are not in hospital settings. That's going to be something that we do a lot of, really starting in January and ramping up. As those two things get started, I absolutely will get vaccinated, and I will be vaccinated very publicly. I would love to get it already, but I felt like it was important for myself to also stick with the prioritization that we have here in Chicago. And some other people are asking, when is the mayor going to get it, et cetera. She also is following really the guidance. We're in healthcare workers right now, and so she's not a healthcare worker. I do take care of patients, as some of you know, in the outpatient setting at Chicago's largest free clinic, Community Health, just on a volunteer basis. And I will also myself be involved in vaccinating patients, and as will people at CDPH. And so I will get vaccinated when it is my turn. And I hope that, as the mayor has said, she doesn't want to step ahead of healthcare workers who are at higher risk of COVID than she is, but she is also very excited to get vaccinated. She will be getting vaccinated publicly. There's a good chance I will do her vaccination, just like I did her flu vaccine this year. We have every confidence in this vaccine, but we also want people to understand as it becomes available, we don't have enough for everybody, and we're going to be prioritizing based on risk and based on these groups. All right. Annabelle Torres from Facebook is saying, I had a liver transplant 3 years ago. I am on rejection medicine, meaning medicine to help keep her immune system suppressed so she doesn't reject the liver for the rest of my life. Can I take the vaccine? So the short answer on that is yes. You would be considered to be someone with an underlying condition who, in fact, probably vaccine would be recommended for, but that is the high-level public health decision. For you and for anybody who has specific questions about their health, I ask you to reach out and have a conversation with your doctor because I want you to have your questions answered specifically. Make sure you feel confident. We've been doing a lot of work already to vaccinate Chicago's to educate Chicago's healthcare workers. As they're getting vaccinated, they're learning more about it. And if you are a healthcare worker yourself, you may have already had that conversation. If you're not a healthcare worker, you would fall down the line where we get to the point where we start talking about people with underlying conditions. People who have immunocompromising conditions would likely be in that group that we would most want to recommend to get vaccinated because you're at higher risk of severe outcome from COVID. But I refer you and anybody else who has a specific question about their condition to their doctor. That's the best conversation to be having. Okay. We've got a question from @CP4Chicago on Twitter. When will daily and cumulative vaccine doses administered be on the data portal? Seems more important to figure than cumulative tests. All right, I love this question, and I actually love the way you asked this because you asked about the data portal, and that is where we plan to start putting vaccine figures. We are planning. We already are. We're starting. Let me take a step back so people understand how this works. Just like testing, no matter where you get vaccinated, if you are a Chicago resident, every test is reported back to the Chicago Department of Public Health. Similarly, every vaccine that is administered, no matter where it is administered, gets reported back. We are all using the state registry system here in Illinois. It's called iCare. It's the existing immunization registry system that keeps track of vaccines. It's the one we already use to keep track of all childhood vaccines. We use it for flu vaccines, et cetera. But as opposed to building a separate COVID vaccine registry. And we're using the state system because we know there are a lot of people who live outside Chicago but work in Chicago. They'll be vaccinated at Chicago hospitals, for example, et cetera, no problem. We know there are people who live in Chicago and work outside Chicago. They'll get vaccinated, not a problem. But we have to make sure that we keep track of this really across the state. So when providers give the vaccine, so this would be our hospitals right now who are doing that vaccinating, they have 24 hours to report in the vaccine that they are giving. That moves into the system. We then, at Chicago, we'll be able to pull that down, and we will start displaying data in the data portal, and then eventually in some interactive maps related to this. We have plans to share vaccine data, not just numbers, but we'll be sharing it similarly to how we share cases and tests now. That's our plan. So we expect when we only have a very few people vaccinated, we wait until there's a little bit of more data from a privacy perspective, but we're planning really, in this week to start already pulling data up. I've got a meeting with the data team today, and I would expect by next week we will start having publicly available data, and we'll be sharing that data by zip code is the plan of where people live. So not where they got vaccinated, but where they live in Chicago. We'll be sharing broadly the ages, race, ethnicity data. We're working on making sure that's reported well. It sounds straightforward. It's not that straightforward, but it's obviously a high priority here for us in Chicago. So there's a lot of work happening behind the scenes right now, just making sure that the data is flowing appropriately and that the hospitals and the tech is all working. But we will be unveiling a data dashboard related to vaccine. At least the data portal. The plan is really in the next week or so, and then increasingly we'll have opportunities for you to be able to engage and look yourself. Nancy Gutierrez on Facebook, does this vaccine have RNA? Yes. So specifically, this vaccine has what's called mRNA, messenger RNA. And maybe, I'm not sure why, Nancy, you were asking that question, but I'm going to take the liberty of explaining a little bit. So RNA is genetic material that teaches, and messenger RNA in particular, it teaches your cells how to make protein. The job of your cells is to make proteins. That is how your body works. And we all have DNA that is our genetic makeup. That lives in the nucleus of all of our cells. When RNA, messenger RNA, is injected into your arm, into your muscle cell, it does not go anywhere near your DNA. It does not integrate into your genetic code. It does not enter the nucleus of your cell. It just takes the messenger RNA, this set of instructions, and uses the cell. The ribosome is the part of the cell that makes proteins, and it teaches your cell how to make a protein that looks like the little spike on even a part of the little spike on the COVID virus. And then your immune system learns to recognize that spike, learns to teach your body how to protect yourself against COVID. So it contains messenger RNA. It is not long lasting. I actually made a little video about this yesterday that we'll be posting with some pictures and some explanations, because I know it's a little bit hard to just hear it. It's better with pictures. And we'll get that posted up in the next couple days. But Dr. Tom Frieden, who used to run the CDC, had a really nice analogy, I thought. He said, think of this mRNA vaccine as an email that's sent to your immune system with a picture to teach your immune system how to fight COVID. That's what it is. And then this email really behaves like a Snapchat. It disappears very, very quickly. The mRNA does not hang around. It does not move into your DNA. It does not get involved. And it really, the reason, why it's this ultra cold and everything is to keep the mRNA stable enough to actually get injected into your muscle cells. So it has RNA, but not in a way that gets incorporated into your genetic code, if that was a question. Andy Silberman on Facebook, how will residents of long-term care facilities be monitored for anaphylaxis if they get the vaccine in their residence? So no matter where you get the vaccine, in a hospital, in a long-term care, in a mass vaccination site, once we're doing those, in your doctor's office down the line, at your employer down the line, in combination with a vaccinating partner, there's a requirement that we monitor people and that we have the materials on hand for anaphylaxis, which is the severe allergic reaction. Again, this is not different from what we do for other vaccines, but particularly with this new vaccine, there's a requirement, amount of time that people have to sit and be monitored. We're planning in Chicago to use that time while we're monitoring people to make sure they have the information about how to enroll in the V-Safe program that will let them report any side effects, make sure they have all the information that they need about their second dose, make sure that everybody is feeling confident about the next steps and what happens next. So we have some education planned related to the time that we are also monitoring people in case somebody were to have an allergic reaction. That same monitoring period will be required in the long-term care facilities for both staff and residents. And we're working with pharmacy partners who will be our strike teams going into the long-term cares. They have all the same safety requirements, all the same training requirements, because obviously we want to make sure that the administration of this vaccine is as safe as it can be. Tiwana Haywood from Facebook, can you clarify when the general public will be vaccinated? Okay. I cannot give you an exact date for that, and that is because so much depends here on how quickly we are able to receive vaccine, on whether it's not just these first vaccines. There are additional vaccines that are still in trials. I encourage you, if you are not a member of a priority group or you really want to get vaccinated, you can still sign up to be part of a COVID vaccine trial. And we need people to sign up to do that because we want to finish these other trials. There are additional vaccines coming that the initial data on phase 1 and phase 2 safety data looks good. There's one coming that's a 1-dose vaccine. We're hopeful that that will come through. There's some coming that are less expensive, that don't require the frozen and the ultra cold. So the question is, how many of these vaccines will actually have data from the big phase 3 safety and efficacy trials that get them approved and get them into use? As we have more vaccine available, that will speed up our ability to vaccinate more people, which will mean moving more into the general population. At the very highest level, we have to follow the federal requirements around prioritization. The Advisory Committee on Immunization Practices and the CDC sets these. So 1A, as you've heard me say a couple of times, is healthcare workers and long-term care facilities. That's where we start. That's where everybody in the country is starting. We expect that at the highest level, the next group or groups will probably be people who are essential workers. And there's some work happening at the federal level, et cetera, defining some of what that looks like. But broadly, we would think about people working in public-facing grocery stores, transportation workers, educators, broadly speaking, people who have a lot of interaction with the public and whose work is sort of essential. So there's going to be a lot more coming about that. And also we expect in next priority groups, people with these underlying conditions, people who are over 65. I can tell you in Chicago, we are also very focused on the congregate settings beyond long-term care facilities. So that would include our homeless shelters, that would include some of the other settings, behavioral health facilities, people where in correctional facilities where we have a lot of people living in close quarters where we've seen outbreaks. So we'll be thinking about those facilities fatalities as well, because keeping outbreaks down keeps cases down. It helps the health department make sure we're distributing resources, and it really helps limit the spread of COVID in Chicago. So I expect, and again, we don't know is the bottom line. I think we'll be in this 1A. We've got 400,000 healthcare workers and long-term care folks in Chicago. So this 1A is going to be very much, it's the focus of December, it's the focus of January, it's going to be the focus of a lot of February. I don't know for sure. My guess is probably maybe late February into March, we might start thinking about moving into some of these next categories. That could be sooner, that could be later. It all depends on how much vaccine is available, how the trials go, et cetera. We are ready and able to push vaccine out as it arrives. But we're sort of thinking, a kind of first quarter, I would think, would be when we probably start to move into these other categories. And that's a lot of people. That's going to take us, again, a number of months. I think it's likely to be much, much later in the spring into early summer before we really have enough vaccine available that we're talking very widespread, come one, come all. Children in particular are not included in these early rounds of vaccine. 16 and 17-year-olds were part of the emergency use authorization for Pfizer. So if there are 16 and 17-year-olds who are working in healthcare settings, or especially once we get into essential workers, they may be included. But broadly speaking, children we've not yet had the trials done to ensure safety and efficacy in children, and those are not likely to come really until the summer. So I think it's likely to be summer before we are broadly vaccinating children, or sort of broadly vaccinating, anybody who wants vaccine in Chicago. And much more about this is coming, but you've heard the mayor say, and me echo, that we're excited to get started with vaccine, but that means that for the next 6 months at least, all of the things that we've been doing, our masking, our social distancing, our being careful with COVID, are not going anywhere. Vaccine will play an increasingly large role in our campaign to protect Chicago, but all of these other pieces are going to come along with it. And, I'm excited by this kind of question that we've got people wanting to get vaccine quickly, because I also want to get vaccine quickly, but we want to be fair, we want to be equitable, and we want to make sure that vaccine is getting where it is most needed. The people with the highest risk of COVID exposure, and we want people who, particularly communities that have been hardest hit by COVID, we want to make sure that there is good access there. So you'll be hearing a lot more about this, but it's going to be a few months before we're really talking in serious ways beyond these first phases. The good news is we're going to learn a lot in these first phases about everything from our tech to our distribution to how many people we can move through mass vaccination sites. We've done a lot of work in modeling using flu clinics around that, but this is going to be a huge logistics mission, a huge communications mission, and we are going to spend a lot of time answering questions just like this. I want questions. I welcome them. They're healthy, and I want people to ask their questions and then feel confident around getting vaccinated when it is their turn. Okay, so we're seeing lots more questions. If we didn't get to yours, for one, you can tune in tonight at 6:00 p.m. when we are doing, it will be on the mayor's Facebook page. It's been widely widely distributed, and I'm going to have some other folks from CDPH on to answer. We will be back multiple times. We're filming a lot here to try to make the frequently asked questions get filmed for some shorter things on social media. We've got these videos coming with some of the science behind the vaccine. So I refer you really first and foremost, chicago.gov. You can go directly to COVID VAX, or from chicago.gov/coronavirus, the vaccines tab at the top of the page. We're adding content really every day. It's a lot of work to get that up and out, but every week we'll be changing the top line messaging. So in terms of some good news, I think a lot of today has just been good news, that certainly, we have started We have started administering vaccine here in Chicago. I said at the press conference on Tuesday that really all I had wanted for Christmas was a COVID vaccine that looked to be very safe and very effective. And this vaccine, certainly in the early stages, was better than I was anticipating for that. I am really looking forward to getting vaccinated by myself, even if it is after Christmas, not a problem. It's that I'll be getting it as soon as it's my turn. I have a lot of confidence in it, and I hope that we can help answer your questions and build confidence as well. So join us tonight at 6 if you want to hear even more conversation about COVID. Please keep sending questions in. We look at them even if we don't get to them live and shape our messaging to help answer your questions. So I am very happy to sign off with saying that we are now in Protect Chicago, not only with all the things we've all been doing, but with vaccine as a part of this. But for the great majority of this, including me, protecting Chicago still means doing the things that we know work. And that means making some different decisions probably about some of your December gatherings. But hope's on the horizon, and we are going to have a much different 2021. I think this will all be in the rearview mirror by the time we get to this point next year. And the more we can do in Chicago to keep our numbers down, to get vaccine confidence up, is what is going to get us past this. And we can do this. We already have done a good job of it in 2020, and I'm looking forward to not seeing too much of a post-holiday bump here, and we will be moving ahead. I want to be talking about reopening as we get further into the winter here, as opposed to needing to pull back. So we can do it, and I will see you for regular Facebook back next Tuesday at 11 a.m. Thanks, everybody.